It's really a pleasure and very gratifying to see so many young people here this time on a very romantic afternoon, okay, with such great weather. And I feel that it's really creditable that all of you are here for an academic exercise. Just give you a half-minute background about myself, that I have been with the CMP College of Homeopathy, which Sandesh didn't tell you, from almost 25 years. I was there. I was associated with it as a teacher since 85, when I was with them for almost 7-8 years, and then now again from the last 4 years. Then there was a big gap, then they called me back. So I've been with homeopathy, and as even as a medical student myself, my family always first took treatment from one of our family friends who was a homeopath, who was an MBBS who converted totally to homeopathy. So my association with homeopathy is very, very long and has been very fruitful and very gratifying. I'm going to present some things which are close to my heart in gastroenterology, which mainly deal with symptom analysis, I think, which as homeopaths is so important for all of you and for all of us also. Right. So I thought I'd first talk about a very basic symptom, which is how you analyze abdominal pain. Pain, as you know, is a very fundamental symptom which brings patients to all of us. If there were no, there are some people who are born without pain endings, and we know that congenitally. And if you can imagine, if the whole world was like that, you and I would almost not exist, because pain is what fundamentally brings patients, pain in every system brings patients to you. So how does one approach a patient with abdominal pain? See, we all know that what acute abdomen is like, okay? We know this, there are a lot of ads, there is a lot of media. Most of the time we are faced with patients who come like this, okay, to us. And we have to analyze their pain, and believe me, analyzing an abdominal pain in someone with this type of physique is one of the most challenging tasks. We know that the abdomen is called the Pandora's box. You know, Pandora was a magician who could take out anything from his box at will. It was so dramatic that you tell him, get a rabbit, he'll get a rabbit, get a pigeon, he'll get a pigeon. So the abdomen is like that. It's full of different organs. So when we say somebody has an acute abdomen, what does one mean? It means that there is a pathological condition which, if you don't diagnose and don't handle quickly, you can be left with a very critical patient. Okay. First, we'll deal with the very acute crisis, which can come to all of us. Okay. Usually, the onset can be from minutes or seconds also, and it can occur over a few hours also. So let us see what are these various conditions. I'm mainly going to dwell on the clinical aspects. I'm not going to go into treatment, because I don't think that is the issue over here, but mainly how one makes a good diagnosis at the bedside in your clinic. So we know that it may be life-threatening, and it can also be very, very mild, something very non-critical also. But the pain can be very severe, even in a non-critical illness. So when I was a resident and I was a student, the motto was, we didn't have ultrasound, we didn't have CT scan, the most sophisticated test which I used to do at KEM hospital, where I was a resident, which at that time was number 2 in India. Okay, incidentally, AIMS was number 1 and KEM Bombay was number 2 on the list of India Today poll, ORG poll, anything. Today, unfortunately, doesn't figure in the top 10 also. But in such a prime institute, you would imagine, nowadays it will be difficult for any of you to imagine that there was no such thing, because these things had hardly come in. In the late 70s, ultrasound came, and the sonologist would do a sonography, and I remember, if I sent a patient to the sonologist with 1 differential, the report came back with 5 differentials. So you were not left any wiser, because the sonologists themselves are on a learning curve. The machines were crude, the images were terrible. So I remember as a resident, acute abdomen aaya, operate, because you couldn't know what is happening. If you don't know what's happening, you had basic x-rays, we'll see what they show. But we know that in some conditions, especially ileus or acute pancreatitis, if you operate, things can go horribly wrong. Your patient can worsen. So they say a good surgeon or a good clinician is one who knows when not to operate. Every surgeon or every physician knows when to operate, but knowing when not to operate, knowing when not to treat is equally important. We know that the diagnosis in an acute emergency should be fast and accurate. Okay? And what are the ways we go about a diagnosis? We go with the traditional methods: history taking, laboratory tests, and imaging. Okay? But important thing is that while all this is going on, the treatment should go on simultaneously. You are dealing with an acute situation. You are not dealing with a chronic situation where you will ask, did your grandfather have the same illness? Where do you stay? Where do you come from? These are not important at this time. Okay? I have purposely chosen a topic because I know that this is something which doesn't come to homeopathy. Okay? And once in a way, when it comes, in my experience at CMP, I find that many people just flounder because they don't have a background of an acute emergency. What are the 5 basic pathologies which can give rise to an acute abdominal pain? You could be bleeding. For example, you could have a bleeding ulcer. You could have ischemia of the bowel or any other major organ. You could obstruct an organ. You could perforate an organ. Or you could have an acute infection in an organ. For example, acute appendicitis, cholecystitis, anything. So these are the basic 5 things around which the whole pathogenesis, the whole clinical scenario will revolve. Just to make it very basic and very, very clinical, we know that the abdomen is divided into 9 segments. Okay, you have these 2 horizontal lines and 2 vertical lines. No? So how do you make these lines? Okay, I'll tell you. It's very simple. The vertical lines are just extensions of the mid-clavicular line. So you take the 2 ends of the clavicle straight line, drop a perpendicular. Those are the 2 vertical lines. How do you get the 2 horizontal lines? No, subcostal is very variable, What is subcostal in me may not be subcostal in you and may not be subcostal in her.
One bit below the sternum.
No, again, these are very variable, no? The xiphisternum can vary. You have emphysema, the xiphisternum will come here. You have a thin chest, your xiphisternum will go up. So it can vary. So whenever you're drawing lines or making what's called surface markings on the body, you should have a fixed set of points. So the fixed point is the up suprasternal notch and down symphysis pubis. Okay, these are fixed points. They are not going to shake. And you take the midpoint of that and you draw your first line up there. Okay, and the second line is drawn along the highest points of the iliac crests. And then you get your 9 segments. It's finished. Okay, and we know that the 1 and 3 are hypochondria, right and left, epigastrium, lumbar, umbilical, lumbar, or flank, you can call them 4 and 6. 7 and 9 are iliac, right and left.